All right, so good morning. So continuing on, today we're going to finish up the series of the CPC review by reviewing the evaluation and management section, the medicine section, and a few tips for when it comes to taking your test. So when it comes to E&M, evaluation and management services are going to be leveled based upon either the medical decision-making, MDM, or the total amount of time in which the provider spent with the patient in reviewing documentation. So you want to select a category or subcategory of the service and review the guidelines, review the level of the E&M service descriptors and examples. There's also an appendix in your CPT book that has different examples of different specialties for E&M coding. And select the appropriate level of the E&M service based on either the medical decision-making or the total time performed on that date of service. So the categories and subcategories in our E&M, we have office visit, then it breaks it down in their subcategory of new patient or established patient. So what makes a new patient? A new patient is a patient who has never been seen in your office, or is a patient who was previously a patient in your office, but it has been 3 years or longer since the last time that they were seen. So an example of an office or other outpatient service category is going to be shown above, like we see for new patient and established patient. The category is then broken down by the new patient or established patient in the 4 levels of codes for each one of those CPT codes. Each code then has a separate requirement for the billing, such as the level of the history, exam, and medical decision-making. While we will look at the various codes and their requirements, we will also learn how to determine the different levels shortly. So like I said, a new patient is a patient who has not received any professional services from the physician or qualified healthcare professional or other physician of the exact same specialty and subspecialty in that group within the past 3 years. An established patient is the patient who has received services within the past 3 years. It could be 2.5 years, but it's still under that 3 years, so that would make them an established patient. If a physician or qualified healthcare professional is on call or covering for another physician or qualified healthcare professional, the patient's encounter will be classified as it would if they would have been seen by the provider who is not available. So there's an additional part of the guideline that states that what that would mean is if they were an established patient, that physician on call would not be able to bill a new patient code. Hospital inpatient and observation care. These codes are used for inpatient facility and partial hospitalization, as well as for patients designated in a hospital outpatient observation status. So this is when the physician is going to the hospital and seeing their patient in the hospital setting, or they're seeing them in that observation care setting. So for patients admitted and discharged on the same calendar date, we're going to use CPT code 99234 to 99236, and then subsequent hospital care codes are used for subsequent visits while they are admitted as an inpatient. And these visits include the physician coming in, reviewing medical record, test results, etc. Here we have an observation table. Observation care is classified by whether or not the patient was seen and released on the same calendar day, or perhaps they had to stay subsequent days. So if they are admitted and discharged on different dates, the initial date CPT code is 99218, 99219, or 99220. If they are admitted and discharged on the same day, 99234, 99235, or 99236. Again, these are based upon levels. Then you have your subsequent, and then your discharge. Your discharge code would be 99217. And then for hospital inpatient services, initial hospital care is reported by the admitting physician on the first date of the inpatient hospital care. For Medicare, these codes are also used by all providers who provide initial consultation services as well. The admitting physician is going to be identified with a modifier AI. And we don't mean artificial intelligence. So our hospital inpatient and observation discharge services codes are based on time. This includes the time spent with the final exam paperwork, reviewing final exam, doing a final exam, paperwork, writing prescriptions, talking with the patient's family, etc., answering all those questions. In your parenthetical notes, it's going to give you information on how to code for concurrent care on the discharge date, as well as for the discharge of a newborn. It's going to tell you to see CPT code 99238 or 99463. Pay attention to those parenthetical notes. For Medicare and office consultations in the medical office are going to be reported with a new or established E&M code. Medicare does not like consultation codes. Cities don't. Inpatient consultations, you're going to report with the initial hospital care code for the first encounter, regardless if it is performed by the admitting physician, and then use an AI for the principal physician of record. Medicare does not, like I said, they don't accept consultation codes. So if a Medicare patient has a consultation, those services are going to be reported under different codes. Like I said, for the consultation done in the outpatient setting, the service is billed with a new or established office or other outpatient service code. If it's done in the hospital, the service is billed with an initial hospital care code, even if the consultation is not the admitting provider. For this reason, the admitting physician put the modifier AI on their claim to help identify them as the admitting provider, and that makes them the principal physician of record. So AI. So now that we have gone through some of the guidelines for the E&M coding, we can talk about the leveling. So when it comes to that, you're going to select your category or subcategory of service and review those guidelines. Can't say that enough, reviewing the guidelines. Then review that level of the E&M service descriptor and their examples, and then select the appropriate E&M level based upon either the total time or the medical decision making. This was one of the changes that was made for 2023, and it's simplified the ambiguity of E&M coding, because it's either based upon the medical decision making or the total time. All right, so we have an example here. Level services based on either the total time or the medical decision making determination. So for an office or outpatient service, SF is going to be, oh, I forgot my abbreviation. It's going to be your, this is going to be your lowest level, because we got rid of the 99201 and the 99211. Low medical decision making is going to be your 99203 or 99213. Moderate, 204 and 214, and your high, 205 and 215. So your total time is defined as the following issues: preparing to see the patient, such as the review of tests, obtaining and or reviewing separately obtained histories, performing a medically appropriate exam or eval, counseling and educating the patient, family, or caregiver, ordering medications, tests, or other types of procedures, as well as referring and communicating with other healthcare professionals, documenting any clinical information in the patient's medical record, independently interpreting results. These are not separately reported, and communicating those results to the patient's family or a caregiver, or even the patient, as well as in the other care coordination. We're not going to count the time spent on performance of other services separately reported, any travel or any teaching that is general and not limited to discussion that is required for the management of a specific patient. Now, if you have a newly diagnosed diabetic and the provider is teaching, or they're teaching the patient how to use, do insulin, give themselves a shot, that would be counted as part of the total time. So when we are looking at E&Ms based on time, here we have 99211. Again, that code has been eliminated. 99212, total time of 10 to 19 minutes. For a 99202, 15 to 29 minutes. These tables are so great to have in your book. Even putting them in the book yourself it will be helpful for you when it comes to determining these levels. For prolonged services, 99417 and 99418. 99417 is for outpatient, and this is used in conjunction with CPT code 99205, 215, 245, 345, 350, and 483. These prolonged care codes are based upon time, and the total amount of time exceeds the highest value in the family. So you do not report any time unit less than 15 minutes. So you would report, so if you're looking at your time limits for 99205 and it goes over that time, then you would be able to add on the 99417 for that amount of time if it exceeds more than 15 minutes. So here we see an example, a new code, 99417, add-on code. It's used only with 99205 and 99215. And you see here, it's talking about how it's adding on that additional time to that office or other outpatient visit. So less than 75 minutes, not reported separately. 75 to 89 minutes would be 99205 times 1, and then 99417 times 1. Because remember, it's going to go up to that additional 15 minutes, up to that time. To me, time codes are a little easier because it shows you the range in that, whereas sometimes the medical decision-making may be a little bit more challenging to determine. So if you're not leveling service based upon time, then other option is the MDM. The guidelines state that history and exam elements should be medically appropriate history and medically appropriate exam. The necessity of the documented elements is going to be determined by the physician or healthcare provider. The history and exam, which must still be documented, are not counted towards the level of the E&M. So we're going to take a look at the next slide. All right, so the number and complexity of problems addressed. So when you're looking at the documentation, for minimal, they're going to have one self-limited or minor problem. So this is generally going to be they're coming in for like a minor illness. For low, 2 or more self-limited or minor problem, 1 stable chronic illness, or 1 acute uncomplicated illness or injury, or 1 stable acute illness, or 1 acute uncomplicated illness or injury requiring hospital inpatient or observation level of care. It's much more laid out when they're talking about the complexity of the problem. So then you have your moderate, and then of course your high. So once you've determined that, it's going to help you determine the level of service. So if we look at category 1, we're going to how many, you're looking at category 1, the quantity review of prior external notes, the review of result, how many were there, and did they order any unique test? So if they did any of those, you're going to mark that and how many did they do. And then under independent historian, this is category 2 for limited. Category 1 is for moderate or high. Assessment requiring an independent historian. Category 2, independent interpretation of a test performed by another physician or qualified healthcare professional not separately reportable. And then category 3, discussion of management or test interpretation with external physician or other qualified healthcare professional or appropriate source. So if any of those were done, you would mark those. If they weren't done, you would leave them blank. And then you would come down here to the bottom and look at your total. So 0 or 1. So 1 category, 1 or less, you have a minimal or none level. 1 of 2, limited. So you'd have 2 category 2, 1 independent historian. And then you would have to have 1 of the 3 here from category 2, category 3, or even 3 out of category 1, and then an independent historian. And then 2 of 3 for your extensive. So then you're looking at the risk and complications and or morbidity or mortality of the patient. The risk of complications is based on these 4 items and or the treatment recommended. So you want to review the definitions with, so we have to identify risk factors, social determinants, as well as prescription drug management that's going to play a role in this as well of the patient's management. So minimal risk of morbidity from additional diagnostic testing or treatment. So example, the provider is recommending rest, gargling because they have a sore throat, elastic bandages, or even superficial dressings for a wound. So there's minimal risk of complications and or morbidity or mortality to the patient. Low risk of morbidity from additional diagnostic treatment or testing. Examples would be over-the-counter drugs, maybe a minor surgery without any type of identified risk. Perhaps patient has physical therapy or occupational therapy, and then even IV fluids without any type of additives. They're just giving them maybe because they're dehydrated. And then moderate risk of morbidity from additional diagnostic testing or treatment. So examples here, RX drug management. So we have a patient who's coming in for management of their prescriptions due to a chronic illness. So that right here puts us at moderate because we don't see it under minimal or low. Decisions regarding a minor surgery with identified patient treatment risks. Decision regarding major elective surgery without any identified patient or treatment risk, and diagnosis or treatment significantly limited by social determinants of health. And then under high, so there is a high risk of mortality from additional diagnostic testing or treatment. And then again, it's going to show those different elements to that high risk of complication and or morbidity. So when it comes to the calculation guide, the final result of each of these 3 sections equal the level of your medical decision making. So you must meet or exceed 2 of the 3 MDM elements to select the overall MDM level. So the number of complexity of problems addressed, the amount and or complexity of data to be reviewed and analyzed, the risk of complications and or morbidity or mortality of patient, then that is going to give you your MDM level. So if you had minimal or none, and minimal, that's going to be straightforward. That's what the SF means, straightforward. If you had low, limited, and low, that's going to give you a low MDM. Under moderate, for moderate, you would have moderate listed under complexity of problems addressed, amount and or complexity of the data to be reviewed. So you see you'd have to have at least 2 of those. And then for your high, you would have to have high under the number of complexity, extensive for the amount and or complexity of data to be reviewed, and then high for risk of complications and or morbidity. So you'd have to have 2 of those to meet that level of high. So there are many factors, as you can see, in determining the level of an MDM service. Constant review of your CPT guidelines and practice will help you with selecting those appropriate codes. So when it comes to E&M modifiers, these are some of the most common ones that we see. Modifier 24 is appended to an E&M service when the same physician sees the patient for an unrelated E&M during the post-operative period. Most insurance have like a 90-day global post-op period. So anything, if the patient's seen during that post-op period, the insurance automatically assumes it's part of that post-op period and doesn't pay it separately. So we would need to add a modifier 24 to indicate that the service is unrelated to the surgery. So that would make it separately payable. Modifier 25, significant separately identifiable E&M service by the same physician on the same day of a procedure or other service. So this is when an E&M service is performed with a minor surgery that is separately identifiable. The 2 services can have the same diagnosis, but they must be separately identifiable. So when the provider performs the procedure, the work involved in evaluating the patient pre-procedure is included. Only work done outside of the normal evaluation of a patient is separately payable. So if you're in doubt whether the service is separately identifiable, make 2 notes from it. Pull all of the documentation related to the procedure out of the note and see if there's enough left over for the E&M service. 32 is for mandated services. These are for services required by a third party, such as court mandate or workers' compensation. And then modifier 57 is the decision for surgery. When the decision for surgery is made during the global period, if the patient sees the provider and the provider decides to perform a major surgery that day or the next day, a modifier 57 would need to be appended to the E&M visit to show that this is when the decision was made to do surgery. Otherwise, the E&M would be considered part of that global package and not paid separately. Crazy. All right. As we continue in our pretest, question 20. Type 1 diabetic was brought into the ER, presents with a rapid heartbeat, pale and sweaty. The provider performs a detailed history, detailed exam, and medical decision-making of moderate complexity. The insulin pump is found to not be delivering insulin. The patient is diagnosed with ketoacidosis and transferred to observation status for monitoring. So this answer would be C, 99218. And then we have T85614A, T38.3X6A, and E10.10. And you see the diabetes code is LAF because they're dealing with the ketoacidosis as well as the insulin pump not functioning properly. So in reviewing our guidelines, observation care level of service is reported by the supervising physician. And so that's going to be our 99218. And that initial observation care per day for the evaluation and management of a patient, which requires 3 key components. So that would make, again, the 99218. And then under our diagnoses, underdose of insulin due to insulin pump failure would be a code from subcategory T85.6, followed by, and then that, you go there, it says it specifies the type of pump malfunction as the principal or first listed diagnosis code, followed by code T38.3X6, underdosing of insulin. So that's where we get the second T code, then followed by our E10.10 for type 1 diabetes mellitus with ketoacidosis without coma. And then question 21. Chief complaint, established patient here for a follow-up on their diabetes and hypertension. Patient presents today for a 6-month follow-up review of their type 2 diabetes and hypertension. The diabetes has been controlled on metformin for 2 years. His hypertension is controlled with metoprolol, started 6 months ago. Patient checks their blood sugar and blood pressure daily and reports WNL. No other symptoms or to report today. Signs or symptoms to report today. CMP and HbA1c lab tests are ordered. They performed an EKG. Patient's wife stated he had an abnormal diabetic eye exam recently, but cannot remember what the ophthalmologist said. The report is not on the chart. I spoke with Dr. Smith, the ophthalmologist, and he advised that he saw some mild changes in the retina and has arranged for a follow-up with the patient. So our diagnosis is controlled diabetes mellitus type 2 and hypertension. The patient was counseled on healthy diet and benefits of losing weight. What CPT codes would be reported? So we have D, a 99214. We have a 93,000 for the EKG, and then we have I-10 for the hypertension and E11.9 for the controlled type 2 diabetes. Now we have the 99214 because we can see here it's established patient. Labs were ordered. The provider spoke with another healthcare professional, and so that upped the leveling for the MDM. So we had numerous, like I said, established patient, problem complexity, data complexity, a risk complexity, and then we had our total time. And then question 22, we have our 20-year-old male patient presents to the emergency department with chest pain and shortness of breath. The physician performs a detailed history, detailed physical exam, and medical decision-making of moderate complexity. A chest x-ray reveals a pneumothorax. The patient gives a history of no recent trauma. Patient smokes 2 packs of cigarettes a day. The ED physician documents a diagnosis of spontaneous tension pneumothorax. So our CPT and ICD-10, we have 99284, which is D, and J93.0 and F17.210. So the J93.0 is going to be for the pneumothorax, and the F17.210 is going to be for the tobacco. So where was the place of service? We said it was in the emergency department. Does the E&M require 2 to 3 level to select, or 3? Required 2. And did the provider interpret the x-ray or just review the findings? So we had evaluation management, emergency department, and then we had the 99284. And then we had again the F17.210 for the nicotine, and the pneumothorax J93.0. All right, and our last section is going to be the medicine section. All right. So with medicine, we have multiple guidelines, multiple procedures, a lot of add-on codes. You're going to see separate procedures, unlisted services or procedures, the use of special reports, as well as materials supplied by the physician and whether or not they are included in the code. So in the medicine section, one of the most common is going to be immunizations and immunization administration. There are 3 sets of administration codes. Counseling can only be done for patients through the age of 18. Over the age of 18, even with counseling, you're going to be using CPT code 90471 through 90474. You want to watch your parenthetical statements. Add-on codes can be used with any of the primary codes, and there are 2 primary codes that cannot be billed. The 2 primary codes cannot be billed together. So 90460 is a primary code, and a 90461 is an add-on code. This is immunization and administration with counseling, billed by component of the vaccine or toxoid, any route of administration. So this is what we would use for adults over the age of 18. And then we have immunization administration, percutaneous, intradermal, subcutaneous, intramuscular per vaccine, 90471, and then add-on code 90472. That is generally what we use for children or immunizations under the age of 18. So the 90471 would be added onto the first immunization, and then the 90472 would be added onto each additional immunization. And then we have immunization administration for intranasal and oral per vaccine. And again, it's just like the same as the 90471 and the 90472. Dialysis is another part we see under the medicine section. So for patients under the age of 2, a full month outpatient facility, CPT code 90951 to 90953, ages 2 to 11 years, 12 to 19, and then 20 plus years. So here you're seeing that these codes are going to be based on age and whether or not they're going to an outpatient facility, if they're doing it at home, if it's being billed by the month, or it's being billed partial month or per day. So examples would be patients hospitalized, patients transient, or even a transplant has been received. So that's when it would be broken down by that partial month. Chemotherapy, treatment of disease by means of chemical substances or drugs. Usually this is for malignancies. These codes are specific to time, technique, and additional substances added. Read the notes of explanation and instruction at the beginning of this section. Advanced training is required for the preparation and administration of these agents. This includes the infusion rate, handling, and disposal of chemotherapeutic drugs. There is significant patient risk related to the administration of chemotherapy. Substances given are prepared specifically for the patient and require advanced staff training to administer them. So what are the services included with chemo? The use of a local anesthetic, IV start, access to the indwelling IV or subcutaneous catheter or port, the flush at the conclusion of the infusion, standard tubing, syringes, and supplies, and the preparation of the chemotherapy agents. So none of these are billed separately. They are all part of the chemotherapy CPT code. All right, and our last pre-test question. Question 23. A patient with hypertensive stage 5 chronic kidney disease and secondary hypoparathyroidism received peritoneal dialysis. The provider evaluates the patient once before the dialysis begins. So this answer would be C, 90945 with CPT code of I12.0 and 18.6, Z99.2, and N25.81. So we've got our hypertension of the I12.0 with chronic kidney disease, and 18.6 is going to be our stage 5, excuse me, chronic kidney disease. Z99.2 is going to be the dialysis, and N25.81 would be the secondary parathyroidism. I think I did that right. Yep. And then you can see here, peritoneal dialysis has either a 4055F code or a 90945 through 90947. So codes 90945 and 47 describe dialysis procedures other than hemodialysis. Examples would be the peritoneal dialysis, hemofiltration, or continuous renal replacement therapies, and all evaluation and management services related to the patient's renal disease on the day of the procedure. And then, of course, we have our hypertension guidelines that presume that causal relationship between hypertension, heart involvement, or even kidney disease. All right, so some tips for taking your AAPC certification exam. And I know we talked about this in a previous webinar, but this is just a few reminders as you get going. So for your ICD-10, you want to highlight your code first notes, as well as use additional notes and your exclude 1 and excludes 2. Make notes to reference those important guidelines. Tab it, highlight it, put notes in it. The only thing you cannot have is extra post-it notes or papers in your coding books. You cannot have it. All you can do is have the tabs on the pages. For your CPT, highlight keywords in subsection guidelines such as new versus established, definitions such as simple, intermediate, and complex repair, musculoskeletal section, open, closed, fixation, percutaneous, manipulation, etc., and those parenthetical instructions, those ever important parenthetical instructions. During the test, listen carefully while your proctor reads the instructions, whether you're taking it at a testing center or doing it as the live remote proctoring. Stay relaxed and confident. You know this, you got this. Testing is nerve-wracking. If you're not nervous, I would be a little concerned. So it is normal to be nervous, but just know that you know the content, and that is why you are here and you're sitting to take your test. Read all the choices before answering. Read the question again, and then stick with your gut. Don't change your answer. Don't change your answer. Stick with that gut feeling, because most of the time, that first answer that you choose is going to be the correct answer. Pace yourself, but also remember you only have about 2 minutes per question, and then answer every question. So if you're getting close to the end of time and you worry you're going to run out of time, just go through and mark your answer. It's better to mark the answer and have a chance of 1 out of 4 getting it right, 25% shot, than leaving it blank and getting marked wrong. Exam results are generally released within 5 to 7 business days. They tend to be a little quicker now that it's electronic and they're using testing centers or the remote live proctoring. If you are taking this before the end of the year of 2023, there is still the option to take in person. But knowing in 2024 is changing to completely either testing center or remote live proctoring. You can check the My AAPC area on the AAPC website, as well as on the AAPC app. You'll get the results on there. Your official documents will be mailed to you with your CPCA on it, and then once we receive they remove your A, then you get sent a new certificate with just the CPC on there. Exam results may not be released over the phone, so they will not be able to give you those results. That way you have to wait until they release it. Thank you. I know you guys got this, so good luck. I have enjoyed being able to share this information with you.